Bismillahirrahmanirrahim. Welcome to this series, MRCP Made Easy. We are going to start with cardiology section. Okay, supraventricular tachycardia is one of the common topics in the exam, either in MRCP Part 1 or MRCP Part 2. It's also the very common problem in real life practice, either in the ICU or CCU or the emergency department or even in the normal medical ward. You may be provided with an ECG like this in the exam, and it's as we see, it's not a complex tachycardia, which is regular, and there is no apparent P waves. You may be asked about the most likely underlying mechanism, or you may be asked about the best management option for this patient. If you have been provided with data of resting ECG, which was normal, so in this situation it may be AV nodal entrant tachycardia, AVRT, or orthodromic reentrant tachycardia, or AVRT, or maybe atrial tachycardia. These are the common underlying mechanisms for the exam, but there are many underlying mechanisms, of course, for supraventricular tachycardia. You may be asked also about the management option according to the situations. If you have been provided with resting ECG or the data about resting ECG which shows pre-excitation, like short PR interval, delta wave, or pre-QRS complex, in this condition, the most likely underlying mechanism would be AVRT, or orthodromic reentrant tachycardia. So these are the causes of regular non-complex tachycardia from guidelines of European Society of Cardiology. The most common causes we will encounter in the exam usually are AV nodal reentrant tachycardia, AV reentrant tachycardia due to accessory pathway, and atrial flutter. Okay, this is our agenda, and these are the commonly covered topics in the exam. The common scenarios which may come in the exam: a patient coming with recurrent palpitation, and the mechanism is not known, and the question asks about the next best course of action. Of course, you want to know what's going on, so you will request Holter 24 to 48 hours, so that is Holter recording, or if the arrhythmia is infrequent, you may request also a loop recorder to record for a longer time. Sometimes the mechanism is known, so the question may tell you that the patient has been diagnosed with SVT or AVRT, and the question asks the best next course of action if the patient has these recurrent episodes. If these episodes are mild, infrequent, and not annoying the patient, so the best course of action will be just reassurance and follow-up. However, if these episodes are frequent or severe and causing distress to the patient, so the best next course of action for these cases is catheter ablation. Of course, if catheter ablation is contraindicated or not feasible, will be drug therapy. But usually catheter ablation is the best next course of action for patients with recurrent severe SVTs. So if the question asks about the acute therapy for a patient presenting with supraventricular tachycardia, so you will ask yourself if the patient is hemodynamically stable or unstable. If the patient is hypotensive or presented with acute severe chest pain or acute pulmonary edema and SVT, so this is hemodynamically unstable patient, and the treatment here will be DC shock, and using synchronized DC shock starting with low energies. So no need for high energies, so starting with 50 joules would be enough for these cases. For a patient with hemodynamically stable patients, so usually we start with vagal maneuvers like Valsalva maneuver, and if this failed, the next step will be using adenosine 6 milligrams, and if this failed, we will repeat the dose of adenosine but giving a higher dose, 12 milligram. So if the question asks about the best next action after failure of 6 milligram adenosine, next step will be 12 milligram adenosine. And if this failed, next step would be using calcium channel blocker like verapamil, or beta blocker like ismolol or metoprolol. And if all of these steps failed, the next step will be DC shock, synchronized DC shock. We must note here, whatever the underlying mechanism, if it is AVNRT or AVRT, if there is accessory pathway or there is no accessory pathway, as long as the patient presented with narrow complex tachycardia, the treatment here would be the same. Vagal maneuvers, adenosine, beta blocker, calcium channel blocker, DC shock. So if the scenario is about SVT in pregnant lady, so the acute therapy would be the same. If hemodynamically unstable, you can give DC shock. If it's hemodynamically stable, you can start with vagal maneuvers, next adenosine, next beta blockers. You can give metoprolol. We have to avoid atenolol in this patient. Also, it's better to avoid IV calcium channel blockers like IV verapamil in these cases. Amiodarone is absolutely contraindicated in these cases. If all of these measures failed and the patient still complains of recurrent SVTs, in spite of long-term treatment with beta blocker or with calcium channel blockers, oral calcium channel blockers, there may be an option for fluoroless caster ablation. Accessory pathway may be manifest, may be concealed. Manifest accessory pathway will show short PR, delta wave, and bronchitis like the ECG presented here. A concealed accessory pathway will not be apparent on the surface ECG. It's detected only during electrophysiological studies. Acute therapy of a narrow-complex tachycardia or supraventricular tachycardia in a patient with known accessory pathway, either manifest or concealed, will be the same. So vagal maneuvers, adenosine, beta blocker, and calcium channel blocker, or DC shocks. There is no difference in treatment as long as it is narrow complex tachycardia. Long-term treatment will be a bit different. So there is no place here for digoxin or beta blocker or calcium channel blockers for long-term treatment. If you have been asked about the best long-term treatment for patients with SVT with accessory pathway, of course it's caster ablation. If caster ablation is not preferred by the patient or it's contraindicated, so the treatment here will be flecainide or propafenone in case of there is no structural heart disease. In case of evidence of significant structural heart disease, we cannot give these drugs like propafenone or flecainide, and the treatment here would be caster ablation. Now this is a different scenario. So a patient came for routine follow-up and ECG was done and it showed accessory pathway or signs of pre-excitation, short PR, delta wave, and bronchitis. However, the patient is completely asymptomatic. So you will be asked about the best next step for this patient. The best next step for these cases is risk stratification. So risk stratification will be done by invasive electrophysiological studies. And if it showed any of the high risk features, the patient must go for caster ablations. If effective refractory period less than 250 milliseconds, or if there are multiple accessory pathways, or if there is inducible tachycardia during the study, the treatment will be caster ablation. However, if there is no one of these high risk features, the patient is considered a low risk and just routine follow up and no need for any intervention. Some high risk patients may have the priority to do these risk stratifications. These patients include the patients who are participants in the competitive sports or some high risk jobs like pilots, like post driver. So these patients also must go for risk stratifications and they have a priority to do such investigation. Okay, if you have been given in the history that the patient has a problem with bronchial asthma or COPD, um, you must avoid beta blockers and you must avoid adenosines from your choices. So if you have been given some choices, you will start with vagal maneuvers, and next choice will be verapamil and not adenosine or beta blockers. In a patient with ischemic heart disease, doing Valsalva maneuver may precipitate angina, so it should be avoided in patient with history of ischemic heart disease. So regarding atrial flutter, of course, there are the common atrial flutters, or called the typical atrial flutters. The most common one is the counterclockwise atrial flutter, which show the sawtooth appearance, where the B wave are negative in the inferior leads, or reverse typical flutter, or called clockwise flutter, where the B waves are positive in the inferior leads. Anyhow, if a patient presented to the emergency department with atrial flutter, and you will be asked about the acute therapy in these cases. Of course, if the patient is hemodynamically unstable, you will go for DC shock, giving low energy synchronized DC shock from 25 to 50 joules. And if the patient is hemodynamically stable, so the first option in these cases will be giving pure potassium channel blockers, dofetilide or epitolide, giving IV. And if it's not available, you may go directly for DC shock, even if the patient is hemodynamically stable. There is no role for amiodarone in these patients. Regarding long-term treatment for these patients, if the condition is common flutter, whatever, counterclockwise or clockwise flutter, or what's called typical flutters, um, the best long-term treatment is catheter ablation. And it's called ablation of cavo-tricuspid isthmus. And if the patient has atypical flutters due to, for example, previous surgery involving the atrium, the best long-term treatment also will be catheter ablation. If catheter ablation is not feasible, uh, rate control may be given to the patient in the form of beta blockers or calcium channel blockers. So, in case of patients presenting with tachycardia, that's persistent tachycardia, and the ECG shows that it's most likely sinus tachycardia, first thing you have to search for a correctable cause. Correctable cause may be physiological cause or may be pathological cause. So maybe fever, hypotension, anemia, cirrhosis, malignancy, pheochromocytomas, whatever. So many physiological and pathological causes should be thought first. If there is no correctable cause, the patient is diagnosed as inappropriate sinus tachycardia. And the best first treatment for this patient will be the funny channel blocker called AVRT. And this may be combined with beta blockers if necessary. So you may start with AVRT, or you may start with beta blocker, or you may give combinations to control this inappropriate sinus tachycardia. So if a patient presented with uh, manifestation of left ventricular dysfunction or heart failure, so presented with shortness of breath, and his ECG showed persistent tachycardia, which may be orthodromic reentrant tachycardia or persistent atrial tachycardia, then usually these cases are diagnosed as a tachy-cardiomyopathy. The best treatment for these cases is to do catheter ablation for the focus of atrial tachycardia, or for the accessory pathway in case of orthodromic reentrant tachycardia. And if catheter ablation is not feasible, medications to control the heart rate may be given, like beta blockers, especially bisoprolol or metoprolol. And if these are not effective and the catheter ablation is not feasible, the line of treatment will be to do AV nodal ablation and inserting a pacemaker. And the type of pacemaker here in these cases will be either a his bundle pacemaker or a biventricular pacing. The ECG shown here shows an arrhythmia which is called long RP tachycardia, and it represents one of the conditions which is called permanent junctional reciprocating tachycardia, and this is one of the common causes of tachy-cardiomyopathy and is treated by ablation of the accessory pathway. So adenosine is the first line treatment for supraventricular tachycardia or even wide complex tachycardia of unknown cause after vagal maneuvers. So if vagal maneuvers fail, the next line will be adenosine, either for another complex tachycardia or unknown wide complex tachycardia. Adenosine, as we know, is an endogenous purinucleoside, and it is eliminated from circulation very rapidly within few seconds. The main mechanism of action is acting on adenosine receptors. It causes hyperpolarization of the cell by activation of inward potassium current, and at the same time it inhibits the calcium current. So the basic mechanism is hyperpolarization of the cell, and plasma half-life is a few seconds, and it's eliminated in the circulation by the enzyme adenosine deaminase. Regarding the response to adenosine, termination is suspected in case of AV nodal dependent tachycardia like AVRT or AVRT. In case of atrial flutter, we will notice like a transient AV block and clarifications of the flutter waves. And in case of automatic tachycardias like sinus tachycardia or focal atrial tachycardia or junctional tachycardia, there will be just transient suppression of the tachycardia and it will warm up again. If there is no effect at all from adenosine, so either the dose is ineffective or inadequate dose, or there may be what's called high septal ventricular tachycardia, which also show a narrow complex. So finally, let's summarize. The basic mechanisms for supraventricular tachycardias are AV nodal reentrant tachycardia or AV reentrant tachycardia due to accessory pathway, maybe atrial flutter, which is called the macro reentrant atrial tachycardia, maybe focal atrial tachycardia, or maybe sinus tachycardia. As we already know, regarding acute therapy, if the patient is hemodynamically unstable, we give synchronized DC shock at low energies. If the patient is hemodynamically stable, we start with vagal maneuvers, then go for adenosine, then go for beta blocker or IV calcium channel blocker, and we have to avoid IV calcium channel blockers in pregnancy, and if this fails, we go for DC shock. Regarding long-term treatment for the SVT, especially AVRT and AVRT, it's mainly catheter ablation, and if it's not feasible, we may give beta blockers or calcium channel blockers for long-term treatment. If the patient has manifest accessory pathway, we have to avoid beta blockers and calcium channel blockers and digoxin. We may give a class 1C antiarrhythmic like flecainide or propafenone, but we have to confirm the absence of any structural heart disease. In case of atrial flutter, the basic treatment is catheter ablation regarding the long-term treatment. Regarding the acute treatment, it's DC shock if it's unstable, and if it's stable, we may give dofetilide or ebutolide, which are pure potassium channel blockers, and if these fail, we may go for synchronized DC shock with low energy. Regarding asymptomatic accessory pathways, we need to go for invasive risk stratifications And if there are high risk features, we need to go for catheter ablations.